Here we are at the last of 4 videos made to show what are the basic functions of the TRIOS intraoral scanner. Today, we will examine an intraoral scan used for the fabrication of a single implant crown. We will also explore the reverse workflow technique, previously published in the Journal of Prosthetic Dentistry, and explain the steps required to execute it effectively. As usual, let's begin with some practical advice that goes beyond the scanning procedures. My recommendation is to regularly ensure your graphics card software is up to date. To do this, use the application displayed on your screen. Once opened, verify that the drivers are update checking the release date. In our case, we have the latest version as indicated by the release date, so no updates are necessary. For peace of mind, you can run a check within this application at least once a month. Once everything is confirmed to be current, you can close the application. Maintaining an updated graphics card is crucial because it significantly influences the performance of the intraoral scanner. An essential aspect when we do intraoral scans where implants are involved is the choice of the scan abutment. The scan abutment is a tool to record the position of the implant and then send it to the laboratory. 2 aspects are fundamental. The choice of scan abutment must be made on whether the mathematical files of these scan abutments can be sent to the laboratory. So we have to communicate with the laboratory what type of scan abutment we use, and if the laboratory does not have one, provide the mathematical files to the laboratory. From my own journey in this field, there's a key insight I'd like to impart. I've chosen to step away from scan abutments made of PEEK. PEEK, while useful, tends to wear out over time, presenting potential issues. As a result, I now lean towards the reliability of metal scan abutments, which in my experience offer better longevity. The patient has a provisional, so it was a patient whose profile was already created. We go to the patient's profile and create a new case. We will decide as usual who to send it to. In this specific case, as usual, our trusty Angelo Canale laboratory in Rimini. We are going to indicate which is the tooth on which we are going to perform our restoration. In this case, the tooth 15. We are going to tell them what type of crown in this specific case. A crown, monolithic or layered zirconia, you will decide. We're going to indicate an approximate color, then we know that we're going to upload and attach a photo, and furthermore, the scanner can give us an indication as to what adjacent teeth shade are. And we are going to mark that this is a screw-retained crown. And then we are going to do a screw-retained restoration directly onto external hexagon connection of the implant. Very important is to choose what is the type of implant, and specifically the implant company, and the type of system, and especially the type of connection. So this is all very important information that is handled in the initial prescription. Since it is only a single crown, we are not going to indicate any type of group. So, crown screwed directly onto the external hexagonal of the implant, monolithic zirconia, and we marked with all implant characteristics and that will support our crown. We always go to indicate the delivery date. On average, we indicate 2 weeks. Then, clearly, it will depend on what is the agreement that you have with your laboratory. Very importantly, having to proceed with the reverse flow technique, we will indicate to our scan software that we will make the interim restoration scan and flag the pre-preparation option. So it is essential to click on the pre-preparation option. At this point, we have completed the prescription. We can add some indication possibly to the lab on the comments part. Specifically, I reiterate what is the prescription already given. Monolithic crown in zirconia on implant cast-free. Perfect. So let's move on to the intraoral scans. We've stressed the importance of daily calibration of the intraoral scanner. From our observations, even if calibrated in the morning, we opt for another calibration before an implant scan. This is due to its noticeable impact on the scan abutment capture. To do this, from the scan interface, select the Tools option and navigate to the calibration function. Simply click, and then we proceed to our calibration tool on the scanner, and we proceed to the first calibration step on the A side of our instrument. We turn the calibration tool on the B side, and on the screen. Let's go ahead. Perfect. At this point we are done. So the advice we give is to check the calibration, precisely because we have noticed that this is a very important aspect for scan taking when scan abutment are involved. Let's dive into our digital workflow. As we've emphasized in previous videos, always ensure the dental chair light is off. Essential. We'll begin with the antagonist scan. Our focus is on tooth 15. So we'll start with its antagonist, the lower arch. The scanning technique remains consistent, as we've discussed before, an oscillatory movement of the scanner. To detect what are the cusps, vestibular and lingual of the posterior elements. In the anterior area, we also proceed with the same movement. You hear the noise of the scanner. It means that the scan is proceeding very well and very fast. When we get to the end of the arch, we decide whether to go buccal or lingual. In the specific case, we will go vestibular, and we proceed. When the scanner is no longer making noise, it means there is a problem. We go back slightly and retrieve a previously detected area. We have finished pretty much the whole vestibular area, and we move at this point lingually. I recommend that you also make the oscillatory movement in the vestibular and lingual zones. This will allow you to detect very smoothly the mesial and distal areas of the dental elements. Very well, we have finished scanning the antagonist. We are going to assess that everything is okay, and then we will proceed with the clipping. Let's trim and clean the posterior areas. Last touch in the lingual area. Let's remember that to get rid of these already trimmed excesses, it will be enough to press the first button and automatically the software will go and clean it up. The antagonist has been detected. We follow the workflow and go to detect the upper arch with the provisional that in the specific case of the software, the scanner is referred to as a pre-preparation scan. This is the scan of the upper arch with the tooth we are going to restore. We indicate what the tooth element is. So where exactly is the 15, so that the software will go and recognize in the scan the element on which we are going to make the crown. We are now going to follow the normal workflow of the scan. We took the antagonist and we took the upper scan with the pre-preparation. It doesn't have to be a single element. It could be even a full arch of interim restorations. The next step for the standard workflow of the scanner is to detect the mucosal tunnel. We instead skip this step and go to take the bite scan. Subsequently, we go back, and that's where we gave the name of reverse workflow, precisely because we do the opposite of what the scanner software protocol. So we go to get the occlusion, the bite scan. The first type of dental occlusion we are going to take is a static bite, so the patient will have to close the mouth exclusively. We are going to check that it is the correct closure of the patient to keep the mouth closed. Let's start from the right side. So any movement we make, the patient has to remain still in this position. We'll initiate from the right side, the location of the implant. The scanner indicates a successful capture of the occlusion, and as I've detailed in prior videos, from here we then proceed slightly forward. The patient stays close all the time, and we go. To detect the static occlusion of the contralateral area, in this case the left, always keeping close. We go to verify that this is the correct patient's occlusion. I would say we are okay. We then proceed with the next step, the dynamic occlusion detection. We record 3 movements today: an anterior disclusion movement, a right lateral movement, and a left lateral movement. You did them while keeping your mouth open. It is very important that you do them while keeping your mouth closed. As I've discussed in our previous video, capturing a larger portion even after the software has successfully recognized the bite area and occlusion is beneficial. This allows us a broader region for dynamic occlusion detection, which you can identify by this blue R. We are ready for the patient-specific motion scan. The patient has been properly instructed, and one thing I had already explained in the previous videos, it is very important to instruct the patient on what are the movements to do, because it is a sort of video recording, and the smoother are the movements, the more accurate our dynamic recording will be. Keep it closed. We position ourselves in an area corresponding to the blue area of the scan. Start only when I tell you to. Slide slowly forward. Slide back. Slide, wait, slowly to the right, go. Go back. Slide, slow to the left, come back. Well, the dynamic scan was done correctly. There were very few stops of the scan software, and therefore the amount of green you saw in the screen was enough to detect the dynamic occlusion correctly. As always, we go to verify that the movements recorded are those that the patient actually makes. In case they were not, we delete the recording. In this case, everything is okay, everything is perfect and correct. Antagonist, upper arch with the temporary inserted, static and dynamic occlusion. We go back, reverse workflow. We can unscrew the provisional and make a scan and impression of the patient's mucosal tunnel. Clearly, we should erase the provisional to prevent the scanner from overwriting, let's say, the mucosal tunnel scan over the provisional scan. This is a very important step. I've heard many people who don't use the trim tool, so occasionally there may remain partial provisional areas of previously scanned interim restoration. So it's very important to go and trim through this button where the scissor symbol is. Let's go slightly in excess. Trimming has been finished. We proceed to scan the mucosal tunnel. Remove the provisional and immediately activate the scanner. As you can observe, I've positioned the scanner over the patient. Why? This step is critical. Remember, we need to remove the provisional and capture the mucosal tunnel. Swift action is essential here. Doing so ensures we accurately record the interim restoration gingival conditioning. Scanning this mucosal tunnel becomes paramount, particularly when our temporary fixtures respect our prosthetic design. Now, we'll swiftly remove the provisional crown and without delay, introduce the scanner to scan the mucosal tunnel. So we proceed to unscrew. We remove the provisional and very quickly we go and scan the whole area. The tissue has not had time to collapse, and now we're going to look at the detail. On the screen, we go to indicate, as usual, the position of the implant. And as you can see, we're going to zoom in on the portion of the mucosal tunnel. You understand well that with this technique, in very few seconds, we have removed the provisional and scanned the soft tissues. So in an anterior area where aesthetics is preponderant, this kind of technique that allows us to detect the mucosal tunnel in very few seconds is really very important. Let's move on to the last part of the flow, which is that of using the scan abatement. So as we said at the beginning, the scan abatement will indicate what is the location of the implant. Having chosen the scan abutment, we are going to place it on the implant. The scan abutment has been inserted correctly. We can proceed with our scan. Once the scan abutment is inserted, a procedure that is optional but very recommended is to lock the surface around the implant, so that the scanner will not detect any tissue collapse that there was in the minutes we have removed the provisional, taking the impression of the mucosal tunnel and applying the scan abutment. We go to scan abutment. We always use the oscillatory and rotation technique to scan all angles of the scan abatement. And we are finished. Checking the scan abutment is very important. The surfaces, the transition areas that we have to check have been detected correctly. The angles and corners are okay. Everything seems very clear here, very precise. So I would say the scan was absolutely successful. The flow has completed. You have seen and understood the reverse workflow technique. Let's now proceed to post-processing. Post-processing is finished. Let's go back to the first case creation page to insert the shade photo that we have just taken. In this window, then you see the scans. Just made with, in addition, as the last one, the tooth shade photo that we are going to send to the lab. In addition to that, as we've already seen and we always do, we're going to enter some information about what are the adjacent teeth shade. So we're going to give that kind of information as well. These are the impressions after post-processing, lower arch and upper arch. On the upper right side, with the use of the reverse workflow technique, we will have the possibility to do a sort of digital cross-mounting, which has a little importance for a simple case like this, but has a lot of importance for more complex cases, where we are going to rehabilitate multiple teeth abutment or even a full arch. So you see, I can decide to place the impression with the provisional. So you saw we remove the one with the mucosal tunnel and we go and insert the one with the provisional. Or vice versa, we can insert the one with the scan abutment. And we go and remove the one with the provisional. So you see the scan abutment here. While such a workflow and these details might seem overly thorough for just a single crown, their significance is truly realized in more complex cases. The last step is to send the case to our laboratory, which will begin the production of our single crown. We're wrapping up our video series on TRIOS's fundamental features with this final video tutorial. We commenced our journey exploring the software setup functionalities of TRIOS scanner. We delved into the initial scans, their informative potential, and their role in enhancing patient communication. Our third video focused on scanning a prepared tooth for making a single crown. Today we've demonstrated the scanning procedures for a single crown on implants. Keep an eye out as we're gearing up to release more video tutorials on the intraoral scanner. We believe these will greatly benefit your practice and your skills using an intraoral scanner.